All right. Hello, everyone. Great to see your faces. Good late morning. Hopefully the Monday has been treating you okay so far. I know things around this time of year get pretty hectic, so thank you for tuning in with us today. Just waiting to see if everybody's audio is connecting, but it looks like we're good. So yeah, we'll go ahead and get started. We're only meeting for an hour today, so we've got a pretty targeted agenda. So we'll go ahead and jump right in, but thank you so much for being here. And yeah, let's go next slide, please, Eva. All right, so we'll be recording today's session as usual, and then those recordings are made available to anybody who misses the meeting and wants to do that. So, all right, so first of all, welcome. If you can update your name in the Zoom just so that it has your organization so folks know where you're coming in from, please use the chat liberally to post thoughts and questions, and that we really want this to be an interactive time. So to get us started, put into the chat a cherished winter tradition in your family. Could be holiday or not, but just something that you and your family like to do during the winter months. Give people a second to get going. Gingerbread cookies, that's a good one. Tamales, all right. My family makes these pepper, they're almost spicy, these kind of pepper ginger cookies. Yeah. Ooh, puzzles. That's a good like cold weather activity. I like that. Nice. Wonderful. Well, thank you. We'll see what we get some more of. But let's move on here. And I will hand it over to Eva to walk us through our objectives and agenda for today.
Thanks, Gabrielle. So our objectives for today are to share important resources related to ECM and CS, clarify.
I was just messaging you. I sent me.
Clarify the DHCS priorities, which have also been introduced as the levers for the CPIs in 2024. We'll have an opportunity to engage with a partnership health plan on the upcoming populations of focus of birth equity and justice involved. And we'll also kind of gauge the group on PDSAs. I know we haven't talked about that in a while, so we'll kind of see where everyone's at and what additional support we can offer. So today's agenda is broken down into 4 different parts. We started with the welcome. We'll move into resource sharing, where we will share new resources and also kind of reintroduce some ones that have been shared previously. We'll move into planning for 2024 with those priorities and focusing on the populations of focus, as I just mentioned. And then part 4 will focus on what to look forward to in session 12, next steps, and also additional resources. So first off, we want to acknowledge all of the amazing work that's happened this year. This includes, obviously the sharing of best practices, all of the relationships that have been built in the CPI, especially in in-person sessions, translating your challenges into policy recommendations, and so much more. So right now, the DHCS survey is live, and this is really to gauge your experience with this CPI, and sharing this information really helps us to meet your evolving needs and just to see, how we've done so far in this initiative. So that link to the survey was included in the email that you received last week. It's also linked here, and we'll also share it in a follow-up email as well. So please fill out that survey by the 31st to make sure that you're able to include your feedback.
I have a question.
Mm-hmm.
How it seems like we just did a survey like less than 2 months ago, maybe 3 months ago. How is this different? I mean, I understand we're trying to push it forward, and there's a large learning curve with not only in the state but with outside the state with all the help that we're getting with this. Is this a different survey? Is it the same survey? Where are we at with that?
I haven't looked at the survey itself yet. Gabrielle, do
Yeah.
you have any insight into how this one is different?
Yeah, no problem. It should be the same survey. It's just they do it, I believe, quarterly. So the DHCS is trying to get a kind of almost real-time sense of how the CPIs are going, how participants are feeling about it, what you want to see differently, and how we're doing as facilitators. So yes, you probably just took this a few months ago. It's likely to be very, very similar. It shouldn't take you more than about 10 or 15 minutes. But it really helps us, particularly since we have such a small group here. It really helps us to get your input on kind of how it's going and what you'd like to see different, if anything.
And then I'm, we have a lot of counties here in California, and I'm getting this survey request from each county.
Yeah.
So if it's the same CPI for 10 different counties, should it just be one survey, or are we trying to granularly analyze that county aspect of that CPI?
So yeah, great question. So it's by region. So each CPI, well, some of the CPIs only cover one county, but most of them cover several. So like this CPI for the Northeast covers 5 counties. And so you would do, if you're part of several CPIs, I apologize because they do want you to do the survey several times, because it's specific to the CPI. And part of that is that the group of stakeholders is going to be different for each region, and also the facilitators are going to be different, right? So Eva and I are your facilitators for the Northeast. In other regions of California, if you're parts of other CPIs, there are going to be other facilitators. And so part of it is that we're graded on how, what participants come back with in terms of feedback. So yeah, I know it's annoying to have to do it a couple different times.
I don't mind. I mean, this is how you have to do things with big projects like this. So I get it. I'm just trying to it does seem like that we're getting these sent quite often, and me, my physician and my licenses and stuff like that cover the entire state of California. So what I do with one county and what I do with another is entirely relatable. But I understand how the county wants to see how, because some counties might be part of a GMC or a COHS or different things, and each county has their own community health and their own county programs that they have to administer. So I do see that, but the previous ones are very general and very broad. So that's where I'm kind of missing the connection. If we get granular with the questions in those as they pertain to that region, I could see where we could up the value of them.
Got it. Okay. Yeah. I mean, and we'll move forward because I know we've got a lot to go through, but just to give you an idea, I'm looking at the survey right now. It asks you about kind of the quality of the content, some key takeaways that you've had, how collaborative the experience is. So things like that, give you an idea. All right, so Eva, and I just put the link in the chat as well if you feel like doing it sooner rather than later. You have until the end of the month. And again, we really, really appreciate your feedback. All right, Eva, I'll pass it back to you.
Great. Thanks, Gabrielle, and thanks for adding that link in there. So we'll move on to resources now, some new resources to make sure that are on your radar. Funding opportunities, walkthrough, and Q&A. This will be the focus of our session next week. We're kind of doing 2 back-to-back sessions that are shorter and really focused on an area that were identified as priorities for the stakeholders in this group. So please join us next week to learn about IPP, cited, and the TA marketplace funding. We will hear from a current CS provider and learn how they scaled their services using both IPP and cited. We'll hear from a current ECM provider about their experience using the TA marketplace and really what that looks like, what the steps are. And you'll also have an opportunity to get your questions answered during a funding Q&A as well. That is a week from today, December 18th at 11:30 a.m. The link to register is there, and we'll follow up with that link as well. In addition, there are some statewide resources from DHCS. They've released several new resources for those involved in the implementation of ECM and CS. Here, there are some spotlights that are available now. This includes the spotlight on children and youth. The PDF guide and the webinar are both linked there, as well as the community support spotlight series, the data sharing authorization guidance, and also the justice involved initiative, including webinars, news, and the draft guidance for that population. And then coming soon is the DHCS statewide best practices summary, as well as the DHCS newsletter monthly highlights. So these are some new resources to make sure that you have, and please be sure to join us again next week to learn more about funding opportunities. So to go into some resources that we've shared previously, but that are definitely worth repeating. This is the list of best practices that have been compiled from this collaborative so far. So these are all best practices that were shared by this group, shared by stakeholders, and this is available, I believe, in the folder that has all of the previous session slides, but you'll also have access to these slides as well. So if you haven't had an opportunity to look at that, make sure you go back and see all of the best practices that have been shared by your peers in this CPI. Additionally, we have some resources from Partnership Health Plan, and you can get all of your questions answered related to ECM and CS via these resources from Partnership. Here you have a link to the PHC provider roundtables for both ECM and CS, as well as the contact information if you have any specific questions. And then linked here as well are kind of all of the additional PHC resources, their webpage, populations of focus, referral forms, information about funding, and then additional sort of billing trainings related to ECM and CS. For ECM and CS policy questions, you can reference the DHCS policy guidance summary that is linked there. The way that it's set up is you can kind of see the part of the provider journey that the policy impacts, how standardized the policy is across health plans, and then also a summary of the revised policy. So that is there for your reference, as well as the DHCS funding sheet, which was created to support organizations in understanding the entities that are eligible for funding, what that process looks like, and what you can use the funds for. So what is permissible for each of the funding sources. And again, that cheat sheet can be found there with all of that specific information. We also wanted to link this resource that was shared by the White House Domestic Policy Council. They released this playbook in November related to social determinants of health. And this may, include resources that are applicable to you and your community. The playbook identifies how the federal government is working to address health-related social needs. And this includes resources for hubs, seeking to develop partnerships with CBOs, and it also focuses on advancing services in historically marginalized community, including rural and frontier communities, which we know is really important for this CPI in particular. And it also provides context at the federal level for efforts similar to CalAIM. So that can be a really helpful resource just to kind of understand how the CPI sort of relates to the federal landscape as well. And now I will turn it over to Gabrielle to move into planning for 2024.
Great, thank you, Ella. So I'm going to go through these slides pretty quickly because I think the concentration for today is really on the new populations of focus. And I'm very grateful that we have Ashley Peel here from Partnership, who's going to lead us through that and then have time for Q&A. So just the heads up, I'm going to go through these quickly, so we can go ahead to the next slide. But I just end to the next one. What we're going to go over briefly are the priority areas that DHCS has outlined for the CPI specifically. So for these collaborative groups, this is what the state is saying that they want us to focus our time on. The good news here is that they didn't come to these from nowhere. They identified these priority areas after reviewing the feedback that they received from the collaborative groups throughout the state. And so you'll see that, at least it seems to me, that the priority areas they've identified very closely align with what we've heard from you all so far in terms of what's most salient. So that's the good news. Just to recap kind of the year so far, we started out almost a year ago, just with problem identification, trying to understand what was happening. We talked through some different solutions, some different best practices. Of course, we're all very far from having completely solved everything. We've gone over policy updates and continued sharing resources. Wanted to let you know we will continue to do this work in 2024. We will continue with the monthly sessions, the office hours, kind of everything that we've done so far, including chronicling what things you all are trying out in terms of your PDSAs, and what the results are from that. But with now this new emphasis as guidance from DHCS around what they're calling levers, or what are really just priority areas. So let's go to the next slide, please, Eva. All right, so if we look at each of these levers, and if we go to the next bullet, yeah, there we go. So if you want to just show us all of them at once, that's fine. So they're around standardizing eligibility, streamlining referrals and increasing referral sources, streamlining authorizations, expanding provider networks and streamlining payments, strengthening market awareness, and improving data exchange, all while trying to drive utilization. Right, so you can see this is very in line with the things that you all have been talking to us about. So if we go to the next slide, for each of these levers or each of these priority areas, DHCS has given us a slide like this that shows what actions they've taken related to that lever, and then what specific questions they have for each of the CPI groups. And so next month in January, we're going to be leading a more detailed conversation with you all around what input you have for these specific questions. We're also going to be trying to tap into some of the other groups like Hank. And if there are other groups locally that you are part of that you think, we should come to and that might have input on these, please let us know. We would love to come to those gatherings. So on the right-hand side, though, I just want you to think about for each of these, whether you have input to share on these specific topics. So if you have input around SNF transitions, kind of what's working, what's not working, what you'd like to see different, or around medically tailored meals, put a little bookmark in your cap, because we will be coming back to that in January. We'll go to the next slide. Similarly, if you have input around the referral process, or the idea of creating a standard referral form to be used statewide, that is something DHCS is really interested in learning and knowing about from those of you on the ground. Go to next slide. This one I think is particularly interesting, which is the state is very interested in presumptive authorizations, which is to say kind of streamlining the authorization process so that if certain criteria were met, you could sort of assume that the services were authorized. And so in particular, are there specific community supports that would lend themselves particularly well to presumptive authorizations? also looking at the retroactive authorization process. We'll go to the next slide. Another thing, do you have input on how to promote contracting, particularly in your area for organizations with either ECM or CS? Input around payment rates, I imagine many folks do. And we know that workforce capacity is a real challenge. And so additionally, any input, thought, ideas around workforce capacity issues. And then we have two more. We'll go to the next one, please. Think about if you have input around how to promote awareness of ECMCS services, both among members, like in the community among members, and also among referring providers. That's a big one. We know that we've heard that from you. Next one is anything around data exchange, billing, or ADT feeds. So you can tell that for each of these priority areas, DHCS's look is kind of reflecting on the input that they've heard from us so far and really trying to get more granular on the specific questions so that they can figure out, is there additional guidance or policy changes that they can implement to help with the implementation of some of this stuff on the ground. So we'll go next slide, please. So again, you'll have this slide deck. Please review it and bring your ideas to our CPI session next month, because we'll be really focusing the discussion there. Also, if you have thoughts ahead of time that could help frame that discussion, please email FRI. That'll really be helpful as we think about how to facilitate that conversation. And with that, I will go ahead and we will pass over to Ashley, who's going to walk us through the new populations of focus going live in just a couple of weeks here. Ashley, I'll turn it over to you.
Perfect. Thank you so much. Hi, everyone. My name is Ashley Peel. I am a program manager at Partnership. I'm on the Enhanced Care Management team. So I am going to be touching a little bit on the new populations of focus, which are right around the corner, which is hard to believe. So if you'd go to the next slide, please. Perfect. Okay. And if you guys have any questions, I know we have some time at the end that I'd be happy to address those. So first spotlight is birth equity. So this one is going live January 1st. A little bit of background on birth equity. So 5.1 million children in California have Medi-Cal. And then we also have data showing that 39% of the births in the state are covered by Medi-Cal as well. So there's lots of opportunity for members to fit into the birth equity population of focus. DHCS has lined criteria for this population of focus, just like all the other ones. So the eligibility criteria to meet the birth equity population of focus is pretty distinct. They are the adults and the youth who are pregnant or up to 12 months postpartum. And then they are also African American, Native American, and or Pacific Islander. So they are counting those as racial disparities. And they've specifically outlined those 3 races to meet this criteria. So next slide, please. Okay, so service examples. What does this population of focus look like? So this might be the lead care manager scheduling appointments, any prenatal or postpartum follow-up appointments, and then also well child visits after baby is born. It could be the lead care manager scheduling an appointment of transportation, since Partnership offers our own transportation benefit. And they could schedule a ride for the member from the hospital back to the home after labor and delivery. And referring members. So like all of our other populations of focus, part of ECM is coordinating the care for these members. So for this birth equity population of focus, this could look like the lead care manager referring the member to community resources, such as the WIC office, and then also putting in a referral for community support services. So any housing and food related items. I did check with our community supports team. They do have to have that medical diagnosis to qualify them for the community support services still. But this could be something that the lead care manager could assist the member with. Next slide, please. All right, moving on to our justice involved. So background here, there is an estimated 80% of the justice involved people who are eligible for Medi-Cal services. And we wanted to break this out into two different phases. So there are two different phases for the justice involved. The one that is going live in January is the ECM benefit. So these are the individuals that are transitioning out of incarceration that are eligible to receive ECM. This is going to be like the same with our current referral system, no wrong door. So if you as a contracted ECM provider are identifying members that maybe they've been released within the last 12 months and they qualify to receive ECM services, you could add these members to your reporting file, submit a TAR for these members. We would also be able to send these members to a contracted ECM provider if the member called into partnership and said, I just was released, I'm looking for services. We can find someone in our network that has the capacity to accept these members. So that's the first phase of the justice involved. There's an entirely huge separate phase that's not going to go live until starting in October, and those are the pre-release services. So that's a targeted set of services that are going to be offered to members who are currently incarcerated and they are set to release. So it's 90 days of pre-release services. And this is the first program in the United States. We are trailblazers here in California. So very excited, a lot to work through, but that is going to start in October 1st, 2024. And correctional facilities have 2 years to implement this new benefit. Next slide, please. All right, so here is the eligibility criteria for the justice involved. So this slide is going to have the adults and children and youth broken out. You'll notice that with some populations of focus, there's different criteria for adults and the children and youth. So for this one, for the adults, and that is 21 and older, it's those who are transitioning from a correctional setting or have transitioned within the past 12 months. And then they also have to have at least one of the following conditions. So either a serious mental illness, SUD, a chronic condition, drawing a blank on IDD, intellectual or developmental disability, traumatic brain injury, HIV or AIDS, or pregnant or postpartum up to 12 months. So most of these members who are going to qualify for this justice involved population of focus are also going to fit into other populations. For the children and youth, it's a little bit different because they only have to be transitioning from a correctional facility. They do not have to have that other complex condition. Next slide, please. All right, so here's a little puzzle piece from DHCS. This is their vision when it comes to justice involved. So most of this is going to go live after October of next year. But just as a visual, so you can kind of see what this is going to look like. So starting on the left there, those are going to be the things that are facilitated within the correctional facility. So members who qualify for pre-release, they are going to start receiving pre-release services once they are signed up for Medi-Cal. They will be provided services for those 90 days before they release. And then towards the end of that, they're also going to get linkages for behavioral health, and then also referred to an external ECM provider if the correctional facility chooses to contract with external ECM providers. So the three on the left there, the darker blue, those are the correctional facility pieces. And then it transitions outside of the correctional facility. So that's when the members get released. They're eligible for enhanced care management, community supports, and then also justice reentry and transition providers who will be helping with the reentry process.
Where is the primary care physician or physician network in this linkage?
The primary care provider?
Yes.
So that's probably going to be after the member gets released and part of the ECM process. So DHCS's vision really is that the member gets released from the correctional facility, and then they are linked to an external ECM provider right away. So they're hoping that the lead care manager could meet the member at the door after they're released. But if that's not possible, which we understand that sometimes it may not be if the member is released at 2 a.m., they're hoping that that's going to happen as soon as possible. And one thing that will also be happening once pre-release services go live is there's going to be a transition plan. So there's going to be warm handoffs from whoever is providing those pre-release services to the member inside the correctional facility. They're going to work with the external person who will be working with the member on a transition plan. So they're going to be aware, and then that lead care manager is probably going to be the person that gets them set up with their PCP.
Yeah, that's a huge lift right there in itself. You know that. And I'm speaking as an RN case manager we're just trying to transition, new member assignment to health plans and not without even these additional complications of them being released from prison with a medical condition that needs continuous care. So this needs a granular look at with all the steps involved, with everything from the delegation agreements to who's going to provide those case management services. Is it going to be PCP centric, or is it going to be health plan centric? So these are things that we should get into these discussions.
Absolutely. Yes. This is going to be huge. There's going to be a lot that we're going to have to work out. Partnership. I know we are meeting with each county specifically in order to discuss what's currently the process, what this might look like. I'm not sure if it's on the next slide. Can we go to the next slide, please?
And actually, I'll also just
Shelly
say
had something to say.
we've got a question from Oretta and then Shelly. So after you finish your thought, actually, just to let you know that you've got a couple hands up.
Perfect. Okay. Yeah, I don't have it in the slide, but there's, of course, this is huge, right? I tried to make it as basic as possible just because I don't want to overwhelm everybody. But there's an entire policy guide of requirements that we're going to have to implement for the justice involved, mostly the things outside of ECM. So the correctional facilities, the counties, but there's two different types of models is where I'm getting to. There's an embedded model, and then there's an in-reach model, and it's going to be up to the correctional facility and the county to choose which model they select. So the in-reach model is going to be when they have people working inside the correctional facilities who are also going to be working with the members after they release. So that may be, the facilities that are already inside the jails working with these members. It may be the county that are eligible to go into the correctional facilities. They have that authorization to go in and provide services right now. So that's the in-reach model. The embedded model is going to be when there's someone in the correctional facility working with the member, and then they warm hand off them to an external provider. So that's what we're expecting to see more of, is the embedded model, or a little bit of both, or maybe a hybrid option. But that's really where we're going to be seeing, the implementation, and trying to work through, once they're released, how are they assigned a PCP? How are they assigned a managed care plan if there's more than one managed care plan in their county? So lots to still be discovered with this.
Great. And Ashley, would you mind just taking looks like a quick question from Oretta?
Absolutely.
And then Shelly, you'll be right after that. Oretta, if you are speaking, I think you're still on mute.
Okay. Hi, good morning.
Hi.
Hi, Oretta.
Excuse me, morning. I had a two-part question. Sorry, my voice. One is, how does this, with the justice involved portion, how do we differ from a probation officer? Somehow I'm wondering, how do we define the different roles. That's one. And two, one of the things I found a lot of times when our patients are in that justice involved part where they're leaving from being incarcerated into, into the general community, it's very hard for them to get reconnected, particularly with their partnership insurance. Because a lot of time we have to be, and then like I had a patient member recently who we had to wait for somewhere from the probation to release them before partnership could say yes, they could get back on. So I'm wondering, are we thinking of how can we bridge those gaps? That was my question. Thank you.
Absolutely. Great question, Aretta. So part of pre-release services, they're changing how the member is going to get reinstated from Medi-Cal. So right now, their benefits are suspended when they get incarcerated. It's going to change to just a play pause button almost. So once the information gets to the county that they're incarcerated, they're just going to push a pause button on their benefits. And then once they get a release date, those 90-day services are going to start if they're eligible to receive them. And then the day that they're released, that pause button is going to be undone. So they're going to have PHC eligibility if they are eligible for it. The day that they get released is the hope from the state. Does that answer your question, Aretta?
Yes, it answered that portion. Thank you. That's wonderful. And
Absolutely.
that's the other portion about how the probation or roles differ. Thank you so much.
Yeah, that's a great question. We're actually meeting with probation in most of the counties just to, this is brand new to them, right? But they would qualify to be an ECM provider because they're working with these members. They have the experience and the expertise, and they could be the lead care managers. But if they are not interested in that, and we are, referring them to lead care managers, I think it's just going to be one of those things with ECM is we have to ensure that there's no duplication going on. I think there definitely is going to have to be multiple conversations on how this is going to look in each county, how we can work together to ensure that we're not duplicating services, and just starting to invite probation to the table and get them involved.
Great. Thank you, Aretta, for those questions. Those are really, really great. Shelley?
Yes, hi everyone. I'm Shelley Davis. I'm the Director of Correctional Services here in Siskiyou County, as well as the Director of Public Health. So my response was more for the gentleman that asked the questions around primary care providers and how we were going to get them to primary care providers. For the past year and a half, we've had a discharge planner in our jail. And we instituted this recognizing that we needed to have some kind of continuity of care outside of jail. So our discharge planner actually meets with that person when they come in and goes over a complete form of who is your primary care provider? Who do you see on the outside for your MAT services? What kind of chronic disease do you have? How are you dealing with that? What kind of medications are you on? Who's your pharmacist? All those questions are asked so that when that person is getting close to release, our discharge planner actually encourages that individual to reach out for appointments around chronic disease management. We will set up the appointments for MAT providers here in our community for that individual. And we put all this into their personal property so that upon release, they're walking out with that information. Sometimes there is a call out to them on the outside once they've been released to see how they're doing. If they need help with getting into behavioral health, that's an example, or either psychiatric services, therapy, whatever they need. So it's worked really good for us for quite some time. We're super excited that partnership's coming in and that, they're going to start, DHCS is going to start paying for these services that we've already been doing ahead of time. But I would really encourage individuals to reach out to their vendors at the correctional level, whether it's WellPath, NAFCare, whether it's the county, to see about putting in that discharge planner, because we're going with that embedded model because we already have it in place. And after that, those are going to give that warm handoff to the ECM and probation, who we also work with at this time. We're going to give that warm handoff to them so that they can continue forward.
Thank you for explaining that workflow. And I completely agree that we need to have the health plan and the PCP all aligned with embedding your workflow into their workflow, because obviously we know maybe not so much in this county, but in the bigger counties with larger populations, there is a large percentage of assignment to primary care that those patients just never get seen by the primary care. We were unable to contact them, and we're able to get that initial health assessment, so on and so forth. So I do hope that we can do a better job, especially when it's wrapped around a chronic condition that needs close management.
Absolutely. And I really feel like this is where that vendor should be involved. The same with me. I'm not a vendor because it's under the county, but we have personal access to all that information. We have personal access to their phone numbers. We have access to their primary care where we can pick up the phone and just call and make that appointment for those individuals. So I think reaching out to those individuals that are running those jail medical departments and, you know, have them be a little more proactive.
Thanks for sharing, Shelley. That's great. Okay, so I think I am just about done on these slides. If you would go back to the previous slide, I think I skipped. Okay, perfect. So who we are looking to contract with, what are the requirements for the justice involved providers? It's basically the same right now as our current requirements. So again, this is more for the population of focus that goes live in January for providing services to the members who are transitioning out of incarceration. So we're looking for organizations that really have the expertise in serving these populations. They do need to enroll in Medi-Cal, but we have a pathway to contract and credential the organization if that's not doable. They have to obtain an NPI, have to submit treatment authorization requests or TARs, and then bill for those services, of course, because we want them to get paid, and then submit the necessary reports to partnership. So basically the same requirements that we currently have for all the other populations of focus. The real difference that we'll see is with those pre-release services and what that's going to look like later on down the road in October through 2026. Next slide, please. All right, and requirements, if you are interested, if you know of an organization that might be interested, the first step is the same. It's completing that ECM readiness questionnaire. So this is the organization's opportunity to provide information to partnership, basically about what their experience is, what counties they would want to serve, what populations they would want to serve. They might want to serve more than the justice population. It's definitely not a pass-fail document, just an opportunity for us to know more about the organization, and then we go from there. Next slide. Okay, that is it for my slides. I know there's probably lots of questions, so if you have any, happy to answer.
Great. Thank you so much, Ashley. And I see that Aretta and Shelley have their hands up. Are these just leftover from before, or are these new questions?
This is Shelley, mine's new.
All right, go for it.
So one of the questions that I have, one of the gaps that we see is getting access to meds so that we can do that whole putting on pause, reinitiating the Medi-Cal application. Because we are not social services, we are public health, we don't normally have that access. Mm-hmm. Our CCS program does have access. How can I get access for that discharge planner? So it's not that stall of, oh, well, let me contact social services, let me wait for them to get back to me, and then we will pause and reinstate. Prior to this coming out, we would actually on a weekly basis send over new incarcerated individuals and those that were released. And the social services department would do all that suspending and reinstating. we want to know how we can get that meds access.
That's a great question. I will have to take that back and see how we can ensure you can get access to that.
That would be great. Thank you so much.
Shelley,
Sure.
thank you for raising this, because I think this is actually one that we can also be raising with DHCS. I know getting meds access for organizations that are outside the social services has been very challenging statewide, as I'm sure you know. Even getting meds access for some of the health plan staff has been really, really challenging, but clearly does have plays a real role in facilitating that Medi-Cal eligibility piece. So yeah, thanks for bringing that up. That's definitely something we can also be uplifting to DHCS. Okay, what other questions? I know this is a big, a big topic and a new one. So comments or thoughts?
Are these the only two populations of focus you're going to talk about today?
Yes, these are going to be our new populations of focus. Yep.
Okay. So how would this tie into some of the other populations? Is that just going to be down the road where we're going to address those? Because I mean, new moms kind of stay in their own category, but this discharge patients from or transition patients from incarceration fall into a lot of chronic disease populations of focus, and some of them might be, eligible under Senate Bill 1004 for the palliative care. Some of them might be necessarily put into a diabetes or a CHF program or respiratory program. And so, when we work with practices, we really work towards the population of focus based on the chronic disease more than we look at the social focus of it. And so, but they cross paths, you know what I'm saying?
Yeah. Yeah, great question. I would say, for ECM, the state has envisioned this is going to be that level of care for the most complex members, the ones who have those clinical barriers, but they also have those social determinants of health. So, it's helping them with their medical conditions, but also helping them with transportation, finding housing, addressing those concerns so that maybe it'll be a little bit easier to address their medical concerns. So, with the other populations of focus, it's kind of the same where, they might fit into multiple populations, but the ECM provider is responsible to coordinate the care for everything that the member needs addressed. So, they don't have to provide the services to the member, but they have to coordinate that care so that it's basically navigating the healthcare system for that member.
Thanks. And Ashley, you have a question in the chat. How soon should organizations be completing their readiness questionnaire? And can this be submitted before January 1st?
Absolutely. Yes. So you can submit that anytime that you are ready. Sometimes it's good to just look at it if you're curious, and we can set up a meeting to discuss any questions you may have, what this might look like for your organization. So that's the first step of the process, is just really filling that out, getting a feel for it. And then once you're approved, then you go through the contracting and the credentialing process, which can take a couple of months. So I would definitely suggest sooner rather than later.
Great. And it looks like we have another question from Oretta.
I do. Thank you. Just some clarification, the population of focus for birth equity, that is different from the other population of focus that had pregnant women. Is that correct?
Yes, very good call out. Yes. So before DHCS had a specific population of focus just for those who were pregnant or up to 12 months postpartum. But then they kind of changed it and they added it to the birth equity population of focus. So pregnant and postpartum is something that kind of falls into the other populations of focus criteria. So if they're pregnant and postpartum and, they have a serious mental health illness, or they're homeless, they would qualify for those populations of focus. but they lumped together the pregnant and postpartum to birth equity. Great question, Areta.
Oh, okay. Thank you. Thanks.
As you can see, these are not distinct. There's a lot of crossover in the populations. Yeah. Great. Well, we have maybe one more question. Any last burning? Of course, you can always contact Partnership for any additional questions. And of course, you know, you can always contact Eva and I, and we can try to get your question to the right place. And it looks like Shelley's saying there should be policies and procedures around all readiness. Yeah, Shelley, were you thinking on the partnership side, or?
The question was if they could submit their readiness assessment before the 1st or January 1st. My question is, should there be policy and procedures around all readiness before submitting?
Got it.
I think
I agree. There needs to be some type of, Shelley, you bring up a good point, because, you know, when we get into these delegation agreements or shared risk agreements we're having with the health plan and the primary care, we need to know what policies we're under with that, the way that lays out for those populations.
Right, but I think it sounds like the question was, do orgs need to have their PMPs already ready when they submit the readiness questionnaire?
Right, because I feel like, you know, we're pretty well ready, but I don't have all my policies.
Right.
So I'm thinking before I even submit it, I should be having all those policies and procedures written around it.
it's definitely not a requirement for us.
Okay.
We understand that a lot of this is building the plane while flying it. So, you know, you may see if you're interested and fill out that readiness questionnaire. And then, you know, you also tell the health plan your capacity on the monthly basis. So some of our providers like to start super, super small and then kind of get their feet wet, feel, you know, how it is, how to implement it best to your organization, and then develop those PNPs.
Perfect. Thank you.
Great. Ashley, thank you so much. This is really, really helpful. We've got 5 minutes, so I'm going to lead us through our ending, which we mostly want to get a sense of where folks are on their PDSAs. Now, if you're new to the group and you don't know what we're talking about, that's totally fine. Don't worry about it. I'm sure we'll go into it in the next couple months. But for those of you who've been with us for a while, this is our Plan, Do, Study Act, which is really just a way to talk and think about process improvements. So let's go to the next slide, please. So we just wanted to do kind of a pulse check on where we all are. So if you can engage with the polls here. First question is, what stage of the PDSA cycle are you currently in? Now, you might have already done several. You might not have started yet. That's okay. We like to periodically check in on kind of where you are in your progress. So thanks to those who've already submitted. I see more and more coming in. Yeah, so it looks like we've got people in really different places, almost at all. All right, we've got at least one person in our group in each of the areas. All right, great. And then the next poll is about what you're working on. So what improvement area have you been working on with your PDSA? Again, you might be working on multiple, so maybe just choose the top one. But, you know, capacity building, care coordination, workflows, contracting. So far, it looks like a lot of workflows and processes, which makes a lot of sense. All right, we're starting to get some more. Great. Thank you so much for participating in this. It really helps us, especially as we measure kind of the progress in the group. All right, wonderful. And then finally, we'll go to our last poll, which is around today's session. And we like to ask at the end of each session, what was most helpful or most salient for you? And so that one should be coming up here soon. And thank you to Eva, who's running all of these in the background. All right. Okay, and we'll go to,
Sorry, I think there's an issue with the third poll.
oh no. All right, well, maybe if you can put in the chat then. The question is, what part of today was most helpful?
I think I just launched it.
What's that?
I think I just launched it. I think you should.
Oh,
yeah.
okay, great. Oh yeah, we have one response. Okay, perfect. Yes. So was it the resources, the reviewing the DHCS priorities for next year, or our presentation and Q&A on birth equity and justice involved populations? And thank you again. This piece in particular is really helpful to us as we do planning for subsequent sessions. Wonderful. All right, neat. Well, Eva, I will hand it over to you to close us out here.
All right. Thanks, Gabrielle. So looking forward to session 12. The link here to register for session 12, and then we'll also send that out after this session. Please feel free to fill that out, and then we'll follow up with the Zoom link like we did for today. Continue working on that PDSA. Again, if you want any support or just want to brainstorm, please feel free to come by office hours or schedule a one-on-one appointment with us, and we can sort of talk you through that process. And we'll send out the updated office hours as well. And again, we just want to thank you all for being here today and for engaging in all of our topics for today. We're looking forward to next week. And as always, a thank you to our Health Begins project team, as well as Gabrielle. And we hope you all have a great rest of your week and look forward to seeing you next time.
Thank you, everyone. Really appreciate you being here.